let's talk about hypertension. You've definitely heard it called the silent killer, and that's not just a dramatic phrase. In this explainer, we're going to pull back the curtain and see exactly why it's so dangerous. We're going to follow the entire path of destruction, right from that single tiny trigger, all the way to the critical, life-saving decisions you're going to make for your patient. Think about this for a second. This is the whole problem right here. Your patient is just sitting there, they feel totally fine, watching TV, no complaints. But underneath the surface, there's a war going on inside their arteries. It's completely silent, and the damage can be permanent. That's why you are so important. You have to be the one to see what the patient can't feel. So here's our game plan. First, we'll look at the spark, the one thing that kicks this whole process off. Then we'll trace the damage and figure out how to spot the red flags that scream crisis. After that, we'll map out the plan for managing it. And finally, we'll get into those tricky exam triggers that you're definitely going to see.
Okay, let's jump in. Section 1, the spark. See, if you want to stop the damage, you have to understand how it starts. We have to go right back to the beginning, to that one little physiological event that lights the fuse on this whole vicious cycle. Understanding the why is literally the key to everything else. It's a chain reaction, and it all starts right here. The kidneys, for whatever reason, sense they're not getting enough blood flow. That's step 1. So what do? They panic. They hit the big red alarm button and release a hormone called renin. That's step 2. Renin then kicks off this whole cascade that ends up creating something called angiotensin II, which is one of the most powerful blood vessel squeezers in the entire body. That squeeze, that massive vasoconstriction, leads directly to step 4, a huge spike in systemic vascular resistance. And that brings us to this word, afterload. It's so important. Think about it. All the pipes in the body just got squeezed tight. Now the heart has to push blood into that super high-pressure system. That resistance, that force the heart has to fight against just to get the blood out, that's afterload. It's like trying to push a boulder uphill 24/7. The heart is working way too hard. And here's the result of that constant battle. Over time, that relentless pressure physically makes the arteries hard and stiff. The heart muscle gets tired, it gets weak, it's exhausted. And those tiny, fragile blood vessels, the ones in the brain, in the eyes, in the kidneys, they just can't take it. They get blown out by the pressure. And that's when we start to see real organ damage. Okay, so we've seen this secret internal process, but how does all that microscopic damage actually show up in the clinic? Let's talk about what you will physically see, what you'll hear, what you'll measure at the bedside. How does it turn from silent damage into numbers and symptoms? This brings us to a really practical question. We get a blood pressure reading, so what? What does it actually mean? How do we take that number and classify it so we know exactly what we're dealing with and what to do next? We've got to have a framework. And this table is basically our playbook. Look at how it progresses. Stage I, pretty much no symptoms. That's that silent killer phase in action. But then as we move into stage 2, that's often when we start to hear the first complaints, maybe a little headache, some dizziness. From there, it's a huge jump up to the crisis levels, which we absolutely have to break down. Okay, lean in for this part, because this is one of the most critical judgment calls you will ever make as a nurse. It's all about spotting the red flags, understanding the difference between a blood pressure that's just really high and a blood pressure that's a true life-threatening emergency. And this slide tells you the one thing that separates them. In both cases, the numbers are sky high, but the absolute key is this. Is there evidence of new target organ damage? A patient with a bad headache and blurry vision, that's probably urgency. But a patient with chest pain, shortness of breath, and you hear crackles in their lungs, that is malignant hypertension. That's the emergency. The organ damage is happening right now. So when you suspect malignant hypertension, you move, and you move fast. Step 1, boom, get them on a cardiac monitor, immediately. Step 2, you're starting that IV medication to begin bringing the pressure down safely. And step 3, you are on that patient doing a rapid focused assessment, listening to lungs, checking for chest pain, looking at their kidney function. No delay. All right, let's shift gears from putting out fires to preventing them. This is where nursing truly shines. This is all about our role in patient safety, in long-term management, and in giving our patients the knowledge they need to take back control of their health. Please burn this into your brain. This is one of the biggest safety points there is. An automated machine gives you a clue. It doesn't give you a diagnosis.
If you get any weird reading, super high or super low, you must check it yourself with a manual cuff. Always. Treating a bad number from a machine without confirming it is how really, really bad errors happen.
Sure, meds are a huge part of the plan, but lifestyle is the foundation. And it's not just random advice. Think back to that vasoconstriction. Why do we tell people to stop smoking? Because nicotine is a beast of a vasoconstrictor. It literally squeezes the blood vessels. Why cut back on sodium? Because it makes you hold on to water, which jacks up the pressure. Every single one of these points directly fights the disease.
And this is a piece of teaching you have to be loud and clear about. Your patient starts to feel good, so they think, hey, I don't need this medicine anymore. You have to warn them you can never just stop. It can trigger this crazy rebound effect where their blood pressure shoots up even higher than it was before, and that can throw them right into a crisis. Okay, time to switch into exam mode. Tests like the NCLEX aren't just about what you've memorized. They're about how you think, how you prioritize. So let's talk about the classic traps they'll set for you when it comes to hypertension. Here it is, the classic scenario. You walk in, the monitor is screaming, 190 over 110. It's a terrifying number, but you look at your patient, and they're just chilling, watching TV, no symptoms at all. The question is always going to be, what is your first action? What do you do right now?
And here's the answer they're looking for. The expert nurse, the safe nurse, does one thing first. Before they call the doctor, before they even think about giving a med, they verify the data. Is that number even real? You grab a manual cuff and you check it yourself. That is always priority number one.
Okay, we've covered a ton of ground. Let's pull it all together. Here is the entire story, from start to finish, the whole disease process in about 30 seconds. Let's run it. It starts with low perfusion to the kidney. That triggers the renin-angiotensin system. That causes massive body-wide vasoconstriction. That makes the heart fight against insane afterload. And over time, that constant pressure fight leads to target organ damage. From cause to crisis, that's the whole flow. So, I'll leave you with this final thought. You've just seen the whole chain of events, every link from that first signal to the final damage. So my question for you is, where do you fit in? Which single link in that chain do you think your nursing actions, your assessments, your interventions, your teaching can have the biggest impact? Where can you break the chain? Think about it.